Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, and that with the simple faith of a child I rely on you. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healthy, healing cure beyond every greed or lure.
Right. It's a great pleasure for me to invite you for this CME Mogappair IMA branch, and we have two young energetic speakers. Both are very well-renowned, well-trained thoracic surgeons from Chennai. They will be talking on surgery for tuberculosis, surgery for lung cancer, and they have significant expertise on the thoracic surgery. And currently, a lot of thoracic surgical procedures happening in Chennai for the management of these patients who would have gone unnoticed. And if you look at the survey, if you go to South Tamil Nadu, there are a lot of patients who have not yet reached this stage. So the more and more these surgical procedures happen, that means more and more we need to increase the awareness so that they get the patients get the benefit from the thoracic disorders. I will just call both of them to introduce. Please come. Rajiv, Santosh, Dr. Ramasamy. Thank you all. Now, first speaker, Doctor.
I'd like to thank the IMA of Mogappair Association, Mogappair branch, and especially Dr. Madhushankar, with whom my family has been associated with so many years, and medically also we've been associated, we've been operating with him for many years. He's been my teacher, and also Dr. Kamalakanan, who is giving me this opportunity for giving this talk. An interesting topic of surgery in pulmonary tuberculosis. So tuberculosis of the lung is pulmonary tuberculosis, and we're going to talk about lung tuberculosis and tuberculosis of the pleural space. So coming to the history of tuberculosis, there has been a long history from the ancient times of the Egyptian mummies, pyramids and time. They've seen that their mention of spine tuberculosis in their sculptures and everything. And 1882, Robert Koch, as we know, has found the tuberculosis bacilli, and as we know, in 1950, the first oral mycobacterial drug, I think it was ethambutol, was found out. And as near as 2010, RT-PCR for tuberculosis diagnosis has really revolutionized the diagnosis of tuberculosis. And in 2020, in the US, they have found a new blood test for diagnosing tuberculosis, and we have not used that in our country as much. Anyway, a little bit about the treatment of tuberculosis in the pre-antibiotic era. The thing is, before antibiotics were there, the treatment was sanatorium treatment and surgical treatment. Surgical treatment was collapse therapies. The principle of collapse therapies was when there's the biggest lesion in tuberculosis were cavities. So how they treated cavities was they collapsed the cavities so that the walls of the cavities touched each other and they got fibrous and healed. Nothing could be done about the bacilli. That had to be treated by the patient's own immunity. So this is the only thing they could do. So different techniques like Freddy crushing, which reduces space in the chest, artificial pneumothorax. This is actually an artificial pneumothorax machine from Santosh Chest Hospital, which was used by my grandfather many years back. It's still there, but it's broken now. It's no more use. The artificial pneumoperitoneum, plombage, where you put lucite balls inside the chest to collapse the chest and collapse the cavities, and use a Jacobius thoracoscope to release adhesions in the apex of the chest to collapse the cavities. So basically all these things are to collapse the cavity and to form fibrosis and healing. Thoracoplasty also is done for the same, but this is still in vogue for certain select patients. But the rest of them have only historical value. These are the lucite balls in the chest. This is the X-ray of a patient who has these lucite balls. I've seen one of these patients, which is treated by my grandfather many years back. He was like 80 plus. So, little bit about the TB burden in India. In 2020, it was 188 per 1 lakh population, and the total number of incidents of TB patients notified during 2021 was 19 lakhs, which is 19% higher than 2020. So, and the estimated mortality rate was 37 per 100,000 population of tuberculosis patients in our country. So, diagnosis, as we all know, clinical is very important, radiological very important, but we should never underestimate the requirement of microbiological, gene expert study and histopathological study. One of these has to be there as far as possible, because many of the times we can miss cancer lesions thinking it is tuberculosis. A lot of cancer like deep-walled cavities, small lesions, even with fibrosis can be cancer also. Like tuberculosis can coexist with cancer. It's always better to get some kind of histopathological or microbiological diagnosis as well. So what are the samples we can get? You get some sputum, or by doing a bronchoscopy, which is better, taking a bronchial wash in the affected area, tissue from lung, pleura or lymph node by either surgical or by image guided biopsies. Like you know, the tuberculin or mantho test, the TB quantiferon gold test has some value, but it cannot tell us whether the patient has active disease or not. So it has value more like in children or in countries, Western countries where the exposure to tuberculosis is not as much. So the current treatment is that tuberculosis is a medically managed disease only. Treatment for surgical treatment is only for specific indications. So by and large, by most cases have to be treated medically only. So when do we do surgery? When the when the TB, which is localized to a lobe, like for example, left upper lobe lesion is there, giving ATT for 6 months, 9 months, 1 year, it is not getting better, patient is still sputum positive, or it is getting bigger, then you knock off the lobe. You do a lobectomy for that patient. Other things, like massive hemoptysis. If there is a lesion, you have started treatment, and the patient starting a cough out, recurrent hemoptysis or massive hemoptysis. This patient can asphyxiate or even exsanguinate to death. So this is an indication for hemoptysis. There are other things like tuberculous empyema. Yes, at that time, just putting a chest tube may not help. You might have to decorticate. What is decortication is? When there is a loculated collection.
The stage tells the anatomic extent of the disease, and this staging is consistent throughout the world. It is easier to communicate the patient details to another center. The slide looks busy, but this is the staging according to the American Joint Cancer Committee, 8th edition, where the T, N and M is described. T is the tumor factors, which mainly tells about the size of the tumor and the involvement of adjacent structures. It starts from T0, TIS, T1, where the tumor is not more than 3 centimeters. T2, the tumor is more than 3, not more than 5 centimeters. T3, more than 5, not more than 7 centimeters. T4 is more than 7 centimeters. T3 lesions, they have invasion into the chest wall, pericardium, or the phrenic nerve, whereas T4 lesions, that can be invasion into the adjacent structures or hollow viscous. The N, which tells about the nodal involvement, it's N0 to N3. N1 is only the intrapulmonary hilar lymph nodes involved. N2 is it's the same side mediastinal or subcranial node is involved, whereas N3 is contralateral hilar or mediastinal node. and supraclavicular nodes. Whereas M stage is M0 and M1. M1 is M1A, M1B and M1C. M1A when there is a malignant pleural or pericardial effusion. M1B is a single extrathoracic met. M1C being multiple extrathoracic met. More importance is being given for the subclassification of the N stage, where N1 is further divided and N2 is further divided. Each of them have prognostic significance, which is expected in the coming next edition of TNL. Just a PET scan alone is not enough to tell that the mediastinum harbors disease here. The PET scan can have false positive. So, always invasive mediastinal staging is essential in order to properly stage the mediastinum. The mediastinum has station 1 to station 14 lymph nodes, whereas station 10 to 14 is in the lung and the hilum, which belongs to N1, 2 to 9 is N2, and station 1 is N3. The mediastinal nodal staging can be done with the help of endobronchial ultrasound, endoscopic ultrasound, mediastinoscopy, which is more invasive, VATS, and video-assisted mediastinal lymphadenectomy, and TEMLA, which is transcervical extended mediastinal lymphadenectomy. The VAMLA and TEMLA being more invasive. So on a PET, we see a negative mediastinal lymph node. This has to be confirmed by an invasive mediastinal staging, either by an EBUS or a VAMLA. If the node is still negative, the patient goes for surgery. Similarly, when the PET is showing a positive mediastinum, this is confirmed again by then the mediastinal node is 100% negative, then he goes for surgery. If the EBUS is positive, then the patient is not a surgical candidate. He has a disease in the mediastinum, he goes for a multimodality therapy, which involves more of a definitive chemoradiation. So what is an early lung cancer and what is a locally advanced lung cancer? This can be understood well from the stage grouping. Any stage 1A, 1B, 2A, 2B comes under early lung cancer. Any stage 3A, 3B and 3C comes under locally advanced lung cancer, where surgery is not done upfront. Any stage 4A and 4B is an advanced disease or a metastatic lung cancer. So when there is a pleural pericardial effusion, when there is pleural nodules or pericardial nodules, when there is a single extrathoracic met or multiple extrathoracic met, then it is a metastatic lung cancer. Looking at the 5-year survival, the best survival is in the stage 1 disease, where at 5 years interval, 90% of them do well. And this is only stage 1A1. As the stage progresses, the survival keeps dropping. Once there is a node, N1 node drops the survival by 50%. When there is an N2 node, the survival drops by 70%. In a metastatic disease, the 5-year survival is less than 10%. There is no present data with respect to the immunotherapy and the targeted therapy, but the immunotherapy and targeted therapy as of now is approved for advanced or metastatic lung cancer. Many centers use it as an adjuvant or a neoadjuvant treatment in addition to the local therapy. There are promising results, and the upcoming HACC will have more information.
Arun, I want to thank the conference for meeting.
Yeah, I forgot that. Thanks a lot.
These two persons are very young and very energetic. I wanted to felicitate them with photo.
Thank you.
Sir, proceed to photo. Sir, see.
And we've been using an IV mount for the last 2 decades, I think.
Yes. Sir, see here, sir.
Thank you.